afternoon, members. It's 2 o'clock on the dot. We're going to start. But before I do that, can I just be allowed to give a moment of silence and reflection, and that moment starts now. Thank you very much. Members, we know the drill. I'm going to now allow ourselves to introduce ourselves. I'm going to start with myself. I am Emery Boyson, and I'm the chairperson for the Standing Committee for Health and Wellness. You may go ahead, members, in no particular order.
Good afternoon, everybody. I'm Benedicta van Minnen, and I'm a member of this committee. Thanks.
Good afternoon. I'm Leon van Wyk. I'm a member of this committee. Good afternoon, Chair, and to Minister, and to all the officials attending.
I'm Thomas Walters, and I'm a member of the committee.
Thank you.
Good afternoon. Good afternoon, everyone. My name is Rachel van Vogel, and I'm a member of this committee.
Good afternoon, everyone. My name is Donita Stevens, and I'm a member of this committee.
Thank you, member.
Greetings to all. My name is Dwayne Jacobs, and I'm a member of this committee.
Thank you, Member Jacobs. Is Member Comfort on the platform?
No,
All right.
Chair.
You'll probably join us. I'm now going to give over Minister, good afternoon, and thank you for making the time. And Minister, I'm going to give over to you for your own introductions, and then for the members of your department, please. Over to you, Minister.
Good afternoon to you, Honourable Chair of the Standing Committee on Health and Wellness, and good afternoon to the Honourable members. My name is Mireille Wenger, and I'm the Provincial Minister responsible for this Vote 6, Health and Wellness. Chair, just a note, the HOD, Dr. Klutty, will be joining us shortly, but he will be on the line in about 15 minutes. However, we do have the full management team here, and we will be ready to answer your questions after the introductory remarks. Thank you.
Thank you, Minister. That is noted. The other officials, just do quick introductions as well.
I'll start with myself. Good morning or afternoon, Chair and members and Minister. My name is Simon Kay, Head of Corporate Service Support in the department.
Thank you.
Good afternoon, Chair and members. My name is Nonhlanhla Andangosi, Chief Director Strategy. Thank you very much.
Thank you.
Good afternoon, Chair and members. My name is Glenn Carrick. I'm the Chief Director of Finance for the Department of Health.
Good.
Good afternoon, Chair, Honourable Chair and Honourable members. My name is Laura Angeletti Dutoit. I'm the Chief Director of Facility Infrastructure Management.
Thank you.
Good afternoon, Chair. Good afternoon, members and everyone. My name is Desra Mokhani. I am the Director for Management Accounting in the Department of Health and Wellness.
Thank you.
Good afternoon, honourable members. My name is Karen Ching, and I'm the Director of Strategy, Policy and Planning.
Thank you.
Good afternoon, all. My name is Lene Pienaar. I'm the Deputy Director for Strategic Planning.
Thank you.
And I think that's it, Chair.
Oh, thank you. Thank you, Minister. Nomonde, any apologies that you're aware of? Nomonde, are you aware of any apologies? Sis Nomonde? We'll come back to Nomonde. Are there any members of the public on the platform? And if there are, if they can just introduce themselves, please. Any members of the public? Doesn't look like it. Colleagues, we all know the drill. The purpose of this meeting is for me to table the appropriations for Vote 6, which is health and wellness, as per the schedule in the Western Cape Appropriations Bill. B2/2025. Minister, I'm going to allow you to give a brief overview. And when Dr. Kluter comes, if he also have some introductory remarks, we can then do so. Minister, I give over to you.
Thank you very much, Chair. I'll just make some high-level remarks regarding the budget for Vote 6, Health and Wellness. And then I think let's just go straight into the questions and we'll take it from there. So the amount to be appropriated for the Department of Health and Wellness for the 25-26 financial year is 32 billion rand, which is up from the 24-25 revised estimate of 30.6 billion, and which represents a percentage increase of 4.5%. This funding to be appropriated is made up of three sources in the main. The one coming from the provincial equitable share, the second is from conditional grants, and then finally from our own revenue. In respect of conditional grants, certain grants increase quite substantially in terms of the percentage increase, and certain other grants have a very minor increase. So if we put all of them together, we're looking at a percentage increase of 2.9% for conditional grants, which equates to about an increase of 219 million rand. In terms of own revenue, we're estimating our revenue target to be around 452 million rand for the 25-26 financial year. However, we do still register the Road Accident Fund and the Department of Justice as risks in those targets. The Provincial Treasury has set inflation at 4.5%. So given that the conditional grants only increased by 2.9%, you'll see that we have some lower than inflation increase on that side, but the overall budget does then keep pace with the projected inflation estimates. You'll see in the budget that we're prioritizing headcount, our cost of employment, to make sure that we can claw back the human resources after a year where we had unusually high attrition. That will then mean that our goods and services budget will remain under pressure in the upcoming financial year. But the story of this budget then is basically a stabilizing baseline compared to the previous financial year. And it is a story of prioritizing our people. So we're making sure that we can fill our posts and make sure that our levels of service delivery remain excellent and that we can care for the residents of this province. And with that, we'll open up for questions following your lead, Chair. Thank you.
Thank you, Minister. Thank you for that brief overview. Members, I'm in your hands. Normally, I allow for comments just on the introductory remarks, but even in this instance, it's up to you, or you can then also suggest to me that we deal with the nuts and bolts or the full content, then we take it from there. Anyone wants to comment on the Member Van Wyk?
Yes, thanks, Chair. I think I will sort of dip into probably the main issues as Minister's already indicated. The whole aspect of employee attrition that the department has seen, and perhaps just try and get a little bit of better understanding on how hopefully we're going to claw back on the shortage of medical staff, and I think we've certainly seen that at site visits as well, both on the call it on the doctor type of side, the medical specialist, and then also on our nursing staff. So I think that is the one issue that then immediately comes up, and then as Ministers also referred to, is this whole aspect of goods and services, and to me it is quite worrying overall that we don't seem to be seeing growth in the spend that we need there. you know, and how that's going to affect us. And then I think the third aspect that we do have is this whole aspect on the stop work orders and the impact of USAID and how we're going to try and manage that situation. So I think those at this stage are sort of my first three questions that I have, Chair. Thanks.
Thank you, Member Van Wyk. Any other comments on the opening remarks? If not, then Minister, I'll give over to you and you can either respond or delegate the response. Thank you, Minister.
Thank you. Thank you very much to the Honourable Member for the question. So we did have an unusually high employee attrition last year. So we were on an aggressive recruitment drive to claw back those positions. You know, the issues that we face with the slow pace of being able to recruit as a result of some of the DPSA regulations remain a challenge. We have seen some improvements, but given the quantum and the scale for a department like ours, with over 30,000 employees, it is a cumbersome process for us. So we have several things that we're doing to try and speed up that recruitment process. And I think I'll ask Mr. Kay if he can just share some of those initiatives with the committee. Then on the goods and services, yes, I mean, it is quite difficult. It's quite a difficult balancing act for us. We've made the decision to focus on our compensation of employees to make sure that we have the people to do the work. But of course, it does mean, again, we will find ourselves in the situation where our goods and services budget will be under significant pressure in the financial year ahead. In respect of USAID, we have presented to the committee on the extent and the scope of the issue. We are working very hard at the moment to see what services the department can absorb, what we can do ourselves. Then we're looking at whether there's other kinds of alternative financing to help fill the gaps for those things that absolutely must continue. And then finally, if there's certain things that unfortunately will have to be stopped or slowed down. So we continue with that work. We're also using the opportunity to see in what ways we can drive efficiency. So by backing spending behind which specific actions and programs do we get the best possible outcomes in relation to TB and HIV. So that work is ongoing as quickly as possible, and we taking it very seriously, and it's something that we will navigate and manage over the coming weeks and months. I'm not sure if anybody else from the department would like to add on there. Let me now hand over. Thank you.
Thank you, Minister. Any official would like to add? It's going once.
Mr. Kay, please go ahead.
Mr. Kay? Yeah, Mr. Kay, I see you.
I was delegated by the minister to respond, so let me respond. So the employee attrition has been almost a perfect storm. So we're talking in this previous period of 1 April 2024 to the 31st of March 2025. And there were new public service regulations which, for all intents purposes, had the effect of doubling the number of applications and halving the amount of time that applications are valid for. So that was the first thing. The second thing was that the austerity measures from the previous year carried on through, where there was a requirement for posts got locked, and there was a requirement that each individual post had to be approved before it could be advertised. And the third thing that came at the same time was the change in the employee pension rules, the two-pot rule. And we had an extraordinary number of resignations of people that wished to take their pensions as upfront cash payments and then reinvest them in other vehicles. So that led us to those three things slowed down our ability to replace. So our capacity to replace at the level that people were leaving, there was a mismatch. So from November of last year, we have now at least managed to gain parity in that the number of people that we are appointing is slightly higher than the continued number of people that leave. And as of March the 9th, we had about 2,281 posts in some form of filling process. So we're taking it very seriously. You'll see that we've prepared it and prepared the budget as if we are going to replace all of those individuals. We have some ideas about how to administratively achieve that, but it is a significant focus on ourselves. I will say also on the goods and services, the main appropriation budget for last year was artificially low because of the way that we were required to balance the budget. And we'll see that the adjusted appropriation, we shifted a fairly substantial amount of money into the goods and services line item in the adjustment appropriation because we had a timing difference in terms of the savings that were coming through on the compensation, and we were therefore able to shift during the adjustment budget process to cover the pressures that are in goods and services. We've tried as best as we can within the fiscal framework to buffer the goods and services pressure, but we will continually manage it because there are a number of variables that come into the play when we're managing budgets in the current expenditure between compensation and goods and services. Thank you, Minister. Thank you, Chair.
Mr. Kay, thank you very much. Members, we're now going to dive into the major content of the Blue Book. Just for the reference, it starts on page 221 until 263, and then from 264 to 295, that is the annexes. And members, I have a proposal for the sake of sequence of events and that we don't page around every now and then. Members, my proposal is that we start on page 221, which is the overview, up until page 238, which would take us to table 8.6. And then members, if we can just refer to the pages where we would like to get some more information, questions or comments. And then when we exhausted that, page 221 to 238, we would then have our second session, which would then be 239 to 263. But I will guide accordingly when we've exhausted the sections that I would like us to deal with. So members, it's now open to you from page 221 up until pages 238. Over to you, members. I know it's straightforward, members. It's one of the most straightforward votes for this day. I see Member Van Wyk again. You can go, Member Van Wyk.
Yes, Chair, you are sort of trying to get a little bit ahead of me, having to turn pages quite quickly. So the first aspect there, I see this whole issue once again of a SARS VAT ruling of 3 October 2024. And it looks like that has got a particular implication on the city of Cape Town. We know that this whole VAT treatment aspect is certainly affecting libraries, for instance. I think if the department can perhaps just tell us or explain to us how that is being dealt with. And then I will sort of just quickly gather my questions for the other pages moving ahead, if I can get a second bite. Thanks, Chair.
Thank you. I will allow a second bite. It will be Member Windvogel and then Member Stevens in that order, please.
Thank you so much, Chair. Chair, my first question is on page 221. The MTEF allocation. Point of reference is the budget allocated to the department. My question regarding the allocated budget, does it take into account the cutting of funding for HIV and TB? Then secondly, Chair, also on page 224, point of reference is TB remains the leading cause of death. I want to understand there how much is allocated to TB clients' loss to follow up, seeing that the department deviated when we look at the annual report of 2024 from its initial target. How will the department ensure that it does not rely too much on partner support initiatives for TB tracing, seeing how the USA cut PEPFAR funding? Yeah, and then also on page 232, Chair, donor funding. I just wanted to check with the department. Is the department in a process of looking for donors to fill the financial gap left by USA? If so, who are those donors and how far are you with the process of are we not affected by the cut? Then page 233, I think that's my last question on your pages from 221 to 238, Chair. Table 8.1. In the department's annual report for 2024, the department mentioned that George closed one of its 4 operating theatres due to cost containment measures, and resulting in increased waiting time and longer times for operations, while all elective service at Paarl Hospital was stopped during the last quarter of the financial year. The bulk of the funding is going to district. So I want to understand, because my understanding is the bulk of the funding is going to district health services, provincial hospital services, and central hospital services. Are these funds enough to ensure the district hospital operates at an optimal level, seeing that district hospitals cater for rural areas as well? Thank you, Chair. I will park there.
Thank you, Member Stevens.
Thank you, Chair. Member Windvogel covered most of my questions, but on the rural communities, what steps are being taken to ensure that rural and underprivileged communities receive adequate healthcare funding? That's my question, Chair.
Thank you, Member Stevens. Minister, over to you and all your officials.
Thanks very much, Chair. Just to alert you and the committee that the HOD had joined the meeting a short while ago. I don't know if it, perhaps you could just greet the committee before we continue.
All right, Minister, thank you for letting us know. Dr. Klute, welcome, and we were waiting in anticipation for you. If you have anything as an overview, HOD, you're more than welcome.
Thank you so much, Chairperson. Good afternoon to the members. Thank you for your patience. I'm safely home, and I'm quite happy to deal with the questions after the minister's responded, member, and then add some comments. Thank you so much.
Thank you, HOD. Minister, we're back to responses. Thank you.
Okay. Thank you very much. Yes, so just on a high level, the SARS issue is something that is a concern, and we're I suppose planning for a worst case scenario, in trying to understand the situation with the VAT is slightly different from the libraries in that the functions have been assigned many years ago, but there is some uncertainty in this domain. And I think the department could probably expand a little bit on that issue. But thank you very much for raising that. I think the committee ought to be aware of the risks in this domain. We're looking at generally at how do we strengthen the health systems, and that work will help support our work in HIV and TB in particular. As the honourable member noted, TB has been the leading cause of death in our province for the last decade. And unfortunately, during the COVID years, we did see a decline in performance. But I'm happy to say we're back to pre-pandemic levels, and we're working very hard to increase the preventative and curative side in respect of TB and HIV. As part of this budget, there will be work done in exactly those domains. Then perhaps the HOD can talk a little bit about the donors. So we are working with some of our current donors to see if there's ways and fits to fill some of the gaps left by USAID. As mentioned, we're also looking internally to see how we can reprioritize and if there's any services that we could absorb ourselves. And then we're trying to look innovatively also in the NGO space, because we're quite concerned that the cessation of funding, not only in health but in other areas, does weaken the NGO sector significantly. So these are all things that we are indeed looking into. And then perhaps the department can answer the question on the district hospitals and in particular rural communities, because we do have a very strong emphasis on making sure that we can deliver services in rural communities despite the distances. And we have very many ways in doing that, whether that be making sure we can get to patients or to make sure that patients can get to us. So I think, if the HOD can maybe just expand on that a little bit. Thank you.
Thank you, Minister. HOD, over to you.
Thank you, Chairperson. So thank you very much for the question of the VAT member, Van Wyk. So on page 226, the second paragraph, we do quite a detailed explanation of the VAT issue. And the long and short is that of that amount of money that we gave in 23-24, which is 592, there's a real risk with this ruling that we have to pay VAT on that amount that we currently contribute to the primary care services in the city of Cape Town. If we pay VAT on that amount, it basically means it is reduced out of the baseline for service delivery. And for us, that brings to the fore the importance of the line we add there of actually dealing with our counterparts in the city and moving forward the issue of provincializing the personal primary care service from the city over to us. So we are in communication with our provincial treasury, we are in communication with the city of Cape Town and with political leaders, because the risk that Member Van Wyk you've picked up is it almost is counterintuitive to pay money for services and then having to pay VAT, which then reduce the amount of services, money that's available for services. So thank you for picking that issue up, and it is it's receiving attention in all the places where we are currently managerially trying to address the issue. Member Van Vogel, your MTEF allocation question on page 221. When you specifically ask whether that includes the reduction of PEPFAR. So what that does include, what this includes, it excludes PEPFAR. That's why when we come, Member Van Vogel, to your question on 232, that's an additional line for donor funds that's not in our voted funds. So the voted funds you see on 221 does not include the additional PEPFAR money. But what is included in the MTEF allocation is the amount of money we pay over to NPOs to render services on our behalf. So there's a distinction between what we pay NPOs from our conditional grants and from our equitable share and from the additional PEPFAR money. And I'll make a clear distinction between the two. So therefore, this amount of money still includes the money we would pay normally for NPOs that works with us, that's contracted with community health workers that are doing outreach and doing TB HIV work, but not the additional PEPFAR money that has come in. And then your question on 224 on TB defaults and referring us to the annual report, you're asking our dependency. So therefore, we're working with NPOs that are being funded by us, whose money has not been discontinued, and we continue to work in partnership with them. But then there is the risk of where the additional PEPFAR money has come in for additional activities that has helped us also in TB and HIV. And I just want to stress this, Member Windvogel, it's not only the PEPFAR money, there's also global fund money that goes into that. That's addition and over and above our voted funds. So there is a real risk. We have, let's say, part of what we get is in our money, which we work with NGOs, and we want to strengthen what we do with NGOs in our attempts to decrease TB defaulter rate. But this additional money from PEPFAR and the Global Fund is obviously, that's the dependency you're talking about. Now, a very important thing for us when we had to look at this impact of PEPFAR, of all the money we receive for HIV and TB, the PEPFAR money makes up 19%, 19%. So that's what we're talking about. So you can imagine 81% is not from PEPFAR. It is in our voted funds and all of this. And it's what we're doing now is to mitigate that 19%. And then your question is a legitimate question. What of that 19% that comes to PEPFAR is contributing to TB, and we're not dependent on that? So we are mitigating, and I'll give you the mitigation for that, because that's linked to your question on 232, which then says in 232, the table therefore has now a vacant table, right? So you see that what we have there, which in brackets it says excluded from our vote appropriation, compensation of employees, US goods and services and transfers, there's zero amounts against that. And just to explain to you now, and this is the complexity, that of the 300, almost 400 million that comes from PEPFAR, the annual basis of the PEPFAR, only about 30 million came to us as a department. So we call that the G2G contract. But the 370 million went directly to NGOs. So what we would have had in here would have been the amounts that would have come only for the 30 million for our own staff and for additional work in the G2G. We're carrying that risk internally because it's only 30 million. The big risk to mitigate for PEPFAR is the 370 million. That's been in a sense, most of it has been stopped, the biggest bulk. The biggest NGO that has received that as an implementing partner is called ANOVA, to where we have now at the point there, virtually all the staff members in ANOVA has received their retrenchment letters. And therefore, by all intents and purposes, all those activities has come to an end. Now, out of that 372, as I've explained to you, ANOVA is a big proportion. There's quite a few staff people that have lost their jobs through these NGOs that got the money directly from PEPFAR. And the bulk of them has been for counseling. It's been community-based counselors and for data capturing. And our mitigation, which the minister referred to, is we are working actually with those implementing agents. I mean, we've worked a path with each one of them. We have mitigated where activities that they discontinue, whether we can pick that activities up in our existing activities at facilities. In many instances, we've taken over activities that they've discontinued. In other instances, we've discontinued activities. And in other instances, there are critical activities that we still need to take up. And therefore, we are looking at options of additional funding potentially to mitigate that. All of those hang in the balance, Member Van Vogel, because there have been engagement between us and the National Department. It would seem that when the budget is finalized, it would seem that additional money might be made available in here for budget pressures that's not voted here, and specifically also money that will be for offsetting some of that risk that I just mentioned to you. That category of activities that cannot be observed, that is critical, that we need to continue. I hope, Chairperson, all of those make sense. I can do a little bit more detail because obviously we will in here be able to give you more clarity once specific amounts come available, once specific strategy come available. But I can just assure Member Van Vogel, we are working with our implementing agents. We're working with all the services. We are on top of exactly knowing which facility are impacted in what activities, and we're tracking it facility by facility. And our implementing partners have been incredible. They've worked with us. We had a meeting with them last week to say thank you to them. But they even saying they're willing to continue to work with us. Whatever resources become available, we'll build better from here. So the big message here is we actually learned that dependency on this money, maybe some of the money was not as wisely spent as it should have been spent. But if we build now forward, we might not have the same amount of money, but whatever we get, we will do it and apply it better for better outcomes. And that's the commitment from all the partners, which has been phenomenal. That's been served at the Council of AIDS. It's also been served at the PCF, and all the mayors, all the municipalities, all the departments are walking this journey with us in a collective. To go to the last question on table 8.1 on 233, I think that's quite an important question, Member Van Vogel. And it adds on to Member Stevens' question as well. So I'm going to try and do justice to that, to explain to you in the following way. When you say that the amount, the main appropriation, and you see it over the 3 years, and you see the main appropriation for district health services, you see the main appropriation for provincial health services, and then you see the percentage change from the revised estimates in those two lines. So you're very right, Member Van Vogel, that the district hospital services and the district health services includes primary care, but it also includes district hospitals. So, Member Stevens, this would be the Hermanus Hospital, it would be the Ceres Hospital, it would be the Robertson Hospital, the Montague Hospital, plus all the primary care. Now, one of the things that we are at pains to do in that line, district health services, is something called, Mr. K, just help me with the equity barometer that we use.
Equitable resource allocation.
Yes, so it's ERA. Yeah, so what that means, members, is we have built something in that on a formula level protects the most vulnerable geographic areas. So that ERA, whenever we go with this amount that's there for district health services, you must now know that is for all those hospitals I mentioned, Montague, whatever, but at that same amount, we must also get Khayelitsha Hospital and Mitchells Plain Hospital. So then we have this ERA that look at what is fair based on the population, based on distances, based on need, all of those things. We have an equity formula that then says we give the resource where it is needed most. So that's the protection we build into that district health services line for rural primary care and also for rural hospitals. The provincial line is the one that Member Van Vogel is asking about. That one is for the regional hospitals. So that will be George, Worcester, and Paarl. Similarly, is in rural areas, but they fund it from the provincial hospital line. But that also competes with Somerset, Mowbray, that's in the metro. Again, this ERA principle applies to that line as well. So George, Worcester, Paarl gets what is fair compared to what would be in the metro. And that's the same formula we built in. So therefore, what we don't foresee, Member Van Vogel, is a lot of what was discontinued as surgical lines, surgical slates in the annual report was due to the pressure on staffing. And Mr. K just explained to you now what we need to do to overcome the staffing, but you will see this budget is about protecting the staffing so that we can get to the place where we can offer the specific theatre list that we need while making sure that there's a fair distribution of services across rural and metro, across regional hospitals, district hospitals, and primary care. Chairperson, I hope that explains and answers the questions. Thank you.
Thank you, Ekodi. That makes sense. Members, follow-up questions. I see Member Van Wyk.
Thanks, Chair. I'm turning to pages 234, 235, and that really relates to infrastructure mainly, and the spending that we are doing there. We're seeing in the main, we're seeing fairly nice increases relative to the overall increase, but I'd just like to get some commentary on how we are faring there or hoping to fare in terms of the maintenance that needs to be undertaken, the refurbishment, rehabilitation, and dealing with those aspects. I saw under the item for machinery and equipment in table 8.2 on page 234, there's quite a bit of a decline there. And then what I've also just looked at is under the professional fees that we have under 8.3, the amount professional fees has gone down a bit in this year, but still the percentage of professional fees relative to the infrastructure work seems to be a reasonably large percentage. So perhaps just to understand that. And then sort of the third part of that in 8.4, under the public-private partnership projects, there are those advisory fees and project team costs there, and perhaps just getting an understanding on those amounts being spent. And I think, bearing in mind that over the page on 236 is the whole reference to the Tygerberg hospital public-private partnership and that huge project, where I imagine a fair amount of preparation work is ongoing there. So I think if we can just get some clarification on these payments, whether they the budgeted payments, whether that is going to help the department in getting its infrastructure sort of back into the attention that it needs, if I could put it that way. Thanks.
Thank you, Member Van Wyk. Member Van Vogel, you may follow up.
Oh, no, Chair, mine is not really a follow-up, it's just a comment. Ek voel baie tevrede in terms of how the HOD, in terms of his reply to my concern, because it has been reported by Ground Up that more than 7,000 children living with HIV in the Western Cape could be at risk of treatment default after the US aid cut. So ek voel baie tevrede as the HOD nou vir ons sê, they are trying under the very difficult circumstances to at least service our people. So ek voel meer gerus. Yeah, on that, on all my questions asked, Chair. But if you allow me, I can start with my second answer of questions.
Member Van Wyk, sorry, Member Van Vogel, before we do that, I'll allow the Minister or the HOD just to respond to Member Van Wyk's questions and comments, and then I'll open up for round two.
Thank you. So there are quite specific questions then around the infrastructure and then the machinery, equipment and professional fees. HOD, do you want to take those?
Yes, Minister, I will start. Thanks. And then I will hand over to either Mr. K or to Dr. Angeleti Tutwe. So let me start off by saying, Member Van Wyk, just at a very high level, our infrastructure team under Dr. Angeleti Tutwe have done tremendous work to get us into a cycle of projects on site. And that's projects on site for major infrastructure, for refurbishment, and for maintenance. So there's a how do I describe it? There's an uptake on getting to the work that needs to be done. Having said that, what you see reflected is therefore then the allocation reflects that reality that we have more projects on site. And therefore you see the infrastructure maintenance refurbishment is, the increases are there, and a relative decrease in equipment, because in the previous years we've actually invested quite a lot in equipment with, let's say, less activity on the works to repair things. But I'm going to ask, I'm not sure, Mr. K, do you want to go, or Laura, do you want to go, just to speak to the professional fees and then also the PPP advisory fees, because that's very much locked into the schedule of work that's now starting to take off in terms of the future work. Laura, over to you.
Simon, if you allow me, so in the issue about professional fees, the issue is that the fees that we are providing are the fees that are recommended by the guideline of the relevant council. So there are no discounts that we are actually working to, with the project that are implemented. So this is why there is an increase, because with the increase of project in construction, there is a supervision to happen on site, and there is a specific percentage of fees that needs to be provided. In relation to the advisory, yes, this is a full team that is busy doing the big project that is 10 billion rand project for Tageberg. The advisory fees is related to the transaction advisor team that is, it's a statutory requirement for the PPP to proceed. We have appointed a team led by Arupa International that are busy. We appointed in 2013, so it's a very long time ago, but they've been working with us for 12 years now. And so far we are achieved the TA1, that is a feasibility study that has been approved, and we are busy now with the second approval from Treasury before going to procurement for the project. And the 5 million rand is related to the in-house project team. That again is a requirement for the department that is embarking in such a PPP to have the in-house team. All the team is on contract, but we have the directors. We have one director, and we have a professional team like architects and also medical advisor or staff. So this is the process. But the rest of the comment that Dr. Cloutier mentioned about additional project are going in construction. So there is a lot of money that now is going in construction. But most of our budget, if you see, is in the sphere of maintenance upgrade. Yeah. So very little is on the new infrastructure. Thank you.
Thank you, Dr. Du Toit. Member Van Wyk, I think you do have the right to kick off round 2 with your questionings and comments. Member Van Vogel. Member Van Vogel, we can't hear you.
Yeah.
Yes.
Am I audible now, Chair?
Yeah, you're audible now. You may go for round 2.
Yes, Chair. My question then is on page 257, Program 8, Health Facilities Management. Chair, according to the Department of Health Wellness Annual Report for 2024, the South River Forensic Pathology Laboratory closed earlier than anticipated in October 2023. So now, due to rapid infrastructure problems. So now, has the closure of the South River laboratory not affect the forensic backlog? And why did the department allocated funds to maintain the infrastructure of the laboratory? And then secondly, Chair, on page 250, Program 5.1, according to the department annual report again in 2024, there has been a reduction of staffing in Tygerberg Hospital and Red Cross War Memorial Children's Hospital.
And this has led to a reduction in surgical operations in both hospitals. So why is the department struggling in retaining staff? Are there provisions in the budget to mitigate the loss of staff? I will park there. Thanks, Chair.
Thank you, Member Van Vogel. Any other members? I don't see any other hands. Minister, over to you or the HOD.
Thanks very much for the questions. And I'm sure the team can expand, but the Salt River pathology lab was closed and the observatory forensic pathology lab was opened. And the observatory forensic pathology lab is more extensive than what the Salt River one was, in that it's a multidisciplinary site that brings together multiple disciplines in forensics as well as pathology, and it is really, I think, first on the continent, if I remember correctly. And at the same time, the Salt River one, the infrastructure was quite run down. So, in fact, the new pathology service is brand new and provides extensive services, and you know, and it hasn't had a negative effect on the backlogs. I don't know, HOD, if you want to expand on that. And then in terms of the reduction in staffing, I mean, that's something we are working on very hard to make sure that we can claw back those posts that were lost through attrition in the last financial year. But at the same time, we do have staff retention strategies. So we have employee wellness programs. We have training possibilities. We encourage development of our staff. We have, you know, very strong focus on appreciation for the staff and the work that they do through various awards and ways that we can show appreciation for the work that they do. You know, I don't know if in the department you'd like to HOD add on that, but you know, we're looking at it both sides. So trying to fill the posts, and then for those staff members that are in the post, how can we make sure that they stay on with us for as long as possible?
Thank you, Minister. HOD, you want to add?
Thank you very much, Chairperson. So yes, just to add a little bit on the Salt River issue, the Minister explained exactly. So actually what OFPI, or the Observatory Forensic Pathology Institute, has resulted in is the reverse of increasing the backlog. It's actually, they've processed more cases. So the backlog in Metro West has actually declined because of the higher operations and the ability to actually render more services. So it's been very positive impact on the platform. In terms of staffing at Red Cross and at Tygerberg, which also then goes over to Grootske as well, the specific staffing challenges here is when you deal with highly specialized surgical procedures. There's surgical specialty nursing is a specific category of staffing that's under pressure. And one of the things that we have, if we do have somebody leaving, it's very difficult to replace that specific skill set. Many times it is people that has worked for quite a while and they're quite senior. So they replace people that's a little bit more junior, and it takes them, you know, time to work up to that. And the bigger thing is there's always been a shortage of people for specific categories of staff. So what we're working with now is we're working with our universities and with our own nursing college to actually start, apologies, to start increasing our longer term throughput. So we want to take a more proactive stance. So it's not just moving one staff member from one place to the other. And this is actually, unfortunately, what has happened now with us trying to fill posts. So Mr. K says we're just about getting ahead of filling the post. But we've picked up a phenomenon is in scarce categories. All we do is we're recruiting people from other places. So, you know, the theatre nurse in Victoria Hospital now goes to Tygerberg. Then we have a vacancy in Victoria Hospital. And between rural and metro. So we're taking a slightly bigger thing in that the rare and the scarce commodity, there's only few people to go around. And there's a movement of people going from one place to the other. What we need to do is we need to get a bigger pool of people. So our intake, and our college is doing phenomenal work. Our college has now got the second graduation through, and we also, with that and the nursing units at the universities, to look at a more proactive throughput, that we have a pool of specialty nurses in 2 or 3 or 4 years' time. From now to then, Member Windvogel is correct. What we need to do now is, there's a big call on us that this restrictive things about the DPSA things, we really need to figure a way of being able to recruit quicker and also more effectively to pull the numbers up. But secondly, we need to look at special incentives to hold scarce staff within our system. And as Minister said, we are looking at that. But I just wanted to bring the point that specifically in highly specialized areas, we're looking at specific strategies for a very scarce group of people. Thank you very much, Chairperson.
Thank you, HOD. Member Stevens, I see your hand, and then I'll recognize Member Windvogel again. You may go ahead, Member Stevens.
Thank you, Chair. I just want to come back to 236 Tygerberg Hospital upgrade. On the mega project of the Tygerberg Hospital, I understood, but my question is, when will Kalbrema receive an infrastructure upgrade, especially the emergency area? As Kalbrema is the primary hospital for numerous rural areas in the metro. And we were there on a site visit.
Yeah.
And what we saw there is like that emergency unit was a total disaster, as it can't take the capacity of patients. So I think we must also look into that. Thank you, Chair.
Thank you, Member Stevens. Member Windvogel, I recognize your hand.
Yes, Chair, mine is just a follow-up on my question on page 257. I think the HOD and the Minister tried to answer me there, but I couldn't remember. English is not my first language. It's a foreign language. I tried to understand, why did the department allocate funds to maintain the infrastructure of the laboratory? So if we are saying it closed down, why are we still fund the infrastructure? Thanks, Chair. If I can get that clarity of understanding of.
Yeah.
Thank you, Chair.
Thank you, Member Windvogel. Minister and HOD, just to add to Member Stevens' question, I want to put my 5 cents in the pot. When we were at Kalbrema, we were informed that it is in the pipeline for an upgrade. So if in the answer, if probably between yourselves and Dr. Dutoy, if there are any dates in view of when that expansion or upgrade would happen. Thank you. Member Van Wyk, and then we'll revert to answering. Member Van Wyk.
Thanks, Chair. Yes, I think I'm happy with the infrastructure comments. I'm sort of moving on to pages 245, 260 in that range, if that is okay with you, Chair.
Yes, we're in that range now. Thank you.
Yeah. So on 245, 246, we see we're dealing with Program 3, Emergency Medical Services. And I see there's an increase there on 246 on table 931, essentially, and also dealt with in 93. In terms of those increases of 4.1%. Overall, and certainly compensation for employees going up by about 7.6%, and goods and services up by about 5%. Are those increases sufficient to address some of the concerns that there appear to be among the emergency medical staff that we've also seen on site visits, where they were saying that they are not sufficient ambulances and not sufficient staff? and the type of pressures that that they find there. So I think that was that area that I was thinking on. I don't know if we moving into section 10 being the other program information on 262. If we're too early for that, then please let me know.
Are we in that range, member? Remember, we are in that range now. We between 2 pages 239 up to 263.
Jeepers.
So,
okay. You're keeping us quite alert there, Chair, that we've got to cover quite a big area, but excellent for that. I see on the personnel numbers in table 10.1 on page 262, we are projecting now a figure of 33,924 in terms of personnel numbers, which is then roughly 480, I suppose, increase off the current year. But if we then look back over the last few years in 23, 24, we had more staff and even higher levels of staff going into the years before that. And so I'm, quite concerned with an increasing population. I hear the hiatus that we've had on an employment side, but, certainly it would appear to me that we probably need more staff than we are going to be able to achieve in the coming year. Also understanding the fiscal constraints that we have. But, maybe just some comments and clarification on that from the team, if that's possible. Thanks, Chair.
Thank you, Member Van Wyk. I see Member Van Minnen, and after Member Van Minnen, I'll give over to Minister and the HOD. Member Van Minnen.
Thank you very much, Chair. Chair, I apologize. It's a point of order. I did notice in the chat group. Member Windvoogel pointed out that English is a foreign language. We can't let that stand. We have to correct it to English is an official language. Thank you. Sorry to be that person.
All right, I'll wait for that comeback from Member Windvoogel. Minister and HOD, over to yourselves.
Thanks very much, Chair. I don't have the information on the Carl Bremer infrastructure or the Salt River, so I'll defer those if that's okay. Then on the EMS question, it's related then to the staffing numbers in that, we can only cut our cloth according to the budget that we have, unfortunately, and the equitable share for health is not growing. And so we have to make do with what we have. It's a very unfortunate situation. We also saw in the previous years then, in fact, that the revision of the health component of the equitable share resulted in a decrease in funding towards health. The last year was the last year of the phasing in of that. So we're in the unfortunate position where the population is growing, but the budget is not. And already the province prioritizes health in that as a proportion of our overall budget. In the Western Cape, we're one of the provinces that spend the most on health proportionate to our budget. So we do prioritize health as much as possible, but even notwithstanding that, unfortunately, we don't have the kinds of budgets which allow us to grow the personnel numbers. So we have to look at efficiency and making sure that we can do the very best we can with with the resources that we do have. On the EMS, I think it's important to say that we understand that there are pressures in the EMS space, and we know that there are long waiting times. There are a few things that contribute to these, amongst others. So, for example, where there are what we call red zones, where ambulances go into areas where there have been attacks on the ambulance personnel or the vehicles themselves. Their police escort is sometimes required, and very often the waiting time for that escort can be as long as 20 minutes before the ambulance can be dispatched. And that, of course, adds to the waiting time, and it's not an ideal situation. And so we're working with our colleagues in the safety environment to see how we can make that better, because if the ambulances can respond sooner, that means in effect that there are more ambulances available. The second is use of ambulances for cases that are not strictly speaking medical emergencies. And we see a few cases where an ambulance is called and the person might be a green patient. That's not to say that they might not be in distress, but it's not an orange or a red. And the ambulances are then dispatched, which means that if a patient is an orange or a red, that means the waiting time will be longer for them. So these are all things that we're working hard to try and unpack, understand, and see how we can mitigate some of these things. And at the same time, as you can see in this year's budget, we're adding 7%, almost 7.5% increase to the personnel. So we are focusing and zooming in on our EMS, as well as trying to be as efficient as possible in their operations. So with that, I'll hand over to you, HOD.
Thank you very much, Minister. So, Chairperson, just for Member Stevens and for yourself, the Karl Bremer Hospital upgrade, it is hospital upgrade, it is not the EC upgrade. Right? The EC is a relatively new building that was completed recently. The experience in the EC speaks to two things. Firstly, that the burden of the people living in the drainage area of Karl Bremer has escalated. The drainage area itself has grown. So the solution actually that we think there is we working with all our primary care facilities that's in the drainage area to Karl Bremer. That's Kraaifontein. That is because Bloekenbos, Wallisdean has expanded. We have to work with Kraaifontein CHC. We have to work with all the others, Delft. We have to work with Elsie's River goes to Tygerberg, sorry. But we have to work with all the surrounding areas in that. So one of the key things that we've learned out of our emergency center work is it is the drivers of why people come into emergency centers. So you guys might all be familiar with the hectares figures that we have. We always talk about hectares. Yeah. And without a doubt, you can then predict month end, weekend, the number of people come in, and in Karl Bremer EC it's chaotic. Actually, every weekend it becomes chaotic. It's we know from the data that we have, those are alcohol related and it's violence related. So that henceforth our work as a violence prevention unit with violence reduction with other law enforcement agencies to start looking at the issue of firearms, knives, but also specifically alcohol, the role alcohol plays in terms of that. So it's really about doing that. But there's other groups of people that also come to the EC. And that is where our work wants to work, and that's why we call it community-oriented primary care. It's the people that comes with diabetes that has not been well looked after. It is, Member Windvogel earlier said, if all of a sudden there's a disruption to HIV-TB support, people will come in ill with TB and HIV. So that's why it's so important we have to go back to primary care, community primary care, really strengthen what happens there. But the big one that we're the most excited about, Member Chairperson, is the ability to go and say, the people that have chronic diseases of lifestyle, that's your diabetes and hypertension, they actually make up quite a lot of people that come in ill into emergency centers. And we really need to look at lifestyle interventions, and we got some exciting programs that we potentially would want to launch to look at all of those. So an EC is only a reflection of how healthy or well people are in the drainage area of that place. And if we continue to expand ECs, we will just continue to expand ECs if we don't go back and look at the reasons why people come into the EC in the first place. That, however, does not speak to the fact that Karl Bremer itself as a hospital has got upgrades lined up. So I'm going to ask Dr. Angeletta just to reflect on the schedule for where the upgrades for the other parts of Karl Bremer is. Laura, do you mind coming in here? Then I'll go to the other issues.
Yes, thank you. Yes, we have a major upgrading of the hospital itself. currently is in design development. So we would like first to do some demolition of all the
Yes,
prefabs that are in the back, and then provide with a long project, because we will have to run the hospital while there is the major upgrading. And then another project that we have that is quite advanced is the acute psychiatric unit.
Yes,
that is, will take 32 beds, psychiatric beds. Is going to be a standalone building, and also in the back, and will be a separate project. But as HOD said, for the EC, we renovated and we extended a few years ago, so there is no plan for further extension. Thank you.
Thank you, Laura. So just for Chairperson and Member Stevens, you can imagine that the psychiatric unit will make a difference to the EC. You can imagine it will take that pressure off, as much as you would see it with Easter River, as much as you're seeing in Kalicha. It will be a similar event. Member Windvogel, sorry, Laura, I was going to ask you, just explain the funds of why the funds were still against Salt River. Sorry, Member Windvogel, I missed that question, so sorry about that.
Now, the Salt River building itself was not our property, was handed back to the National Department of Public Works in December 2024. We have in total 17 forensic pathology labs. And of course, among each other, there is the big one that Minister mentioned, that one in observatory, but we had to maintain the facility. So we don't maintain anything at the Salt River because the building has been given back to the owner. Thanks.
Sorry, so it's a bit of a lag, Member Windvogel. The lag was we had to vacate the building, but we still had to keep the building before it handed it over to the National Department. So that discontinued, and that building is now handed back to them. So sorry about that, Member Windvogel. Then I think for the question that Minister asked for Member van Wyk, the question is whether that staffing is sufficient for EMS. The Minister explained we're looking at the operation for EMS. But if I can just use an example, we went to Radikotse and Lapeminnik, and I remember, Chairperson, I know you guys also have done your visits. Yeah. One of the biggest things that impacts on EMS is what is called inter-facility transfer. It's when somebody is already at the hospital, but we don't offer that service for the person and they have to go from one hospital to another hospital. So one of the biggest things, it is the call on EMS to pick somebody up in the community, take them to a hospital, assess in the hospital, and then a call from the hospital to take them from one hospital to another hospital. So it's almost like double work for EMS. That's besides the fact that in many instances they have to wait to go into the communities and be escorted in. So that affects the whole operation of EMS. So one of the things that we would like to say from Member van Wyk, it is as much as we want to take that double work away, we want to look at the ways that we can offer as much definitive care where EMS goes to first time. So there's two things. It's flexibly allowing our EMS not to go to a place where they know they're just going to have to come back and pick up the person again and take it the second time. It is to take that person from where they picked up directly to the place where they're going to get definitive care. So it is our ability to do that. And it's our facilities to work with our EMS to release the patient as quickly as possible as they arrive in the facility. Many times the EMS crew are waiting to find somebody in a hospital to hand over before they can go. So there's a concerted effort. You might have heard the term ecosystems. We're now trying to work in geographic ecosystems, and EMS becomes a central core of that ecosystem. Everybody in the ecosystem now realizes EMS is a scarce resource, and we must not waste the scarce resource. So we must not inappropriately call EMS so that we can, when we need them most, we can use them effectively. So as much as we will be adding some staffing, we need to take the added burden of EMS to make them more effective so that they can respond to what we got. I just want to come to the staffing question that Member van Wyk asked. So just to indicate, Member van Wyk, that 33,000 is quite significantly up from the baseline of the current the financial year that we're about to finish. So that 33,000 plus goes up from the 32,000 plus. And if you go back to the numbers that you are speaking about, that is comparable to what we had in 23-24, the previous financial year. But 21, 22, and 22, 23 is a little bit skewed because we added COVID contract posts into that. So if you take the COVID contract posts out, or if you think of COVID contracts to be taken out, we are talking about re-establishing or stopping a baseline and setting ourselves onto a forward trajectory. So I think the point you're making, Member Van Wyk, we agree with you. We don't want to see the numbers, that the numbers insufficient, but just to be said that those 2 previous years actually was artificially inflated with the contracts from COVID. And then we're now back at 23-24. And our idea is to continue to build from this point onward a steadying of our staffing over the MTF period coming forward. Thank you, Chairperson.
Thank you, HOD. Members, any follow-up questions or additional questions? Member Stevens, I recognize your hand.
Thank you, HOD, for shedding light on Calbrema's EC side. But I would suggest that day hospitals should then be upgraded and better equipped to serve patients on a higher level, to try to take off the pressure of the ECs such as Calbrema. That would also lower the influx of patients, especially weekends. And at the moment, I know at some of the day hospitals, as I did quite a few oversight visits, that the day hospital, that patient sits at the moment like for 2-3 days without helping them. And where by the time they do help that person, they must call the ambulance themselves to take that person to hospital. And there was quite a few loss of lives since December due to negligence from, I know specifically the Cryvenden Day Hospital, but that happens all over at the day hospitals where they are not really equipped or enough staffing to serve the community, and that's why the influx at the hospitals are so much. Thank you, HOD.
HOD, I saw you nodding on the day hospital comment.
I don't know if the minister wants to respond, Chairperson. Sorry, I was jumping the gun. Sorry about
no
that.
problem.
That's fine. Go ahead, please.
Thank you. No, I get very excited about this, Member Stevens. I used to work in the day hospital, and that's why I get excited. So my apologies, Chairperson. There's something that we need to really unpack about the role of day hospitals. And you can understand this also then goes back to our city-province divide conversation. There's something about the ability that we are reactive, Member Stevens. We're reactive. We wait for somebody that is ill, that comes to us, and then we respond. Now, the iller the person becomes, the more they exceed the capacity of the people that's in the day hospital to deal with it. Hence, the Member Windvogel's questions, we fully agree with, is going out into communities and from the day hospital itself, doing outreach, because we now have the data to tell us, where's our diabetics? Are they coming in early? Do we go and find where they are? Make sure that our TB and our HIV patients are treated on their medication so that they don't come in ill to the places. And therefore, the day hospitals is a very crucial entry point into looking after all the clinics that's in the day hospital's drainage area. So as much as we want the EC to be protected, like you say, by the day hospital itself must think of itself that its own EC must also be protected by strong clinics, community health workers, and what happens in a community setting. That's the whole idea of community-oriented primary care. So I've spoken to some doctors working in those day hospitals. And the big question is how many of them are supporting the treatment in the clinics early so that fewer people also come in very ill into the day hospital. So it's a whole chain knock-on effect, but we're very, very supportive of what Member Stevens is saying, because that's the entire system that we want to build. It's the system that's strengthened closest to where the person lives. And that's why limited service package offering is not an option. We need to increase what we can do in a geographic area for the people living there and not allow them to get so ill that they then have to kind of sit for a long time in an emergency center. But thank you, Chairperson.
Thank you, HOD. Members, I don't see any other hands. And in the beginning of, at the start of the meeting, there were no members of the public. So I don't know whether we've been joined in the meanwhile by members of the public? And if we do, I'll allow now for the members of the public to engage with us and with the officials. Members of the public, it's going once, it's going twice. Seems that we do not have members of the public. They'll probably join us when we're going to have our second bite at this appropriation of vote 6. Members, in the absence of any further questions, I am now going to allow the Minister and the HOD to make their closing remarks, please.
Thank you very much, Chair, to you and the members for the questions and for engaging on the budget.
Short and sweet. Thank you, Minister, HOD.
Thank you, Chairperson. At the risk of talking longer than my boss, I feel obliged to say thank you for the oversight. Really, again, from my side, my humble apologies for not joining from the start. And just to say to the members, we really appreciate the oversight, the rigor, and actually a deep understanding of the work that we do. So we really appreciate the level of engagement, and yeah, we take this very seriously. So thank you very much for the way that you're engaging with us. Thank you, sir.
Thank you, HOD. Thank you, Minister. Before I let you go, before I release you, I just want to make a comment by saying, Minister and Member van Wyk. I see your hand, Member van Wyk, before I do my closing remarks.
Yes, Chair. All that I would just want to say is there's no doubt that this has been a massive effort that the department has put into this budget. And, I think the detail that there is and the explanations that have been given, I think we need to commend the department on the work that they've done. And this, it's really, it's excellent work. Thank you.
Member van Wyk, you're not supposed to use my script. That's my script. But Minister and HOD and the team, Member van Wyk, have really touched on the gist of what I was going to say. But I want to say this in the midst of witnesses. I normally measure the success of the department and this committee on the constructiveness from the members, and especially the opposition members, because it's easy to have a perception that the ruling party members would just, read from a script. But I must say that this is one of the committees where indeed our engagement, even with the professionals, is of a very, very high standard. There are times, and many a times, I hear the members also, when they make comments, to say that when they forward questions to the officials via you, HOD, the responses are professional, the responses are on time. And I want to say to Minister and you, HOD, and the team, keep up the good work. We fully and truly understand the tremendous pressures that you guys are operating under, but we see the light at the end of the tunnel. And with that said, thank you very much. You may be released, and we will see you, I think it's on the 7th of April in the House. Thank you very much.
Thank you, Chairperson. Thank you to all the hardworking staff. Thank you very much, everyone.
Thank you. Thank you to the
Thanks very much to the team. Thank you. Thank you, Chair.
Thank you very much. Enjoy the weekend.
Members, don't disappear. Thank you.
Likewise.
Members, don't disappear. We are almost done. Members, thank you very much. I would now then give an opportunity for any recommendations and any additions that needs to be noted. But also, please be aware, just a reminder, members, that the recommendations will not be included in this report, but it will be included in the minutes. So members, any recommendations? It's going once. Member van Wyk.
Yes, Chair, I think I've probably asked enough questions. I was going to hope that some of the colleagues would pick this up, but I think you know, as we have seen and worked through this budget, I think those of us, and I think all of us here today, have been on a number of site visits to health facilities, and we have a very good idea of the stresses and the strains that the health team has been working under. And I think it is quite heartwarming to see the increase that has come through to this department to deal with this budget of about 4.5% on an overall basis. And therefore, it is very commendable to see how those additional funds have been allocated, and certainly the efforts that are underway to deal with various aspects within the health chain, you know, whether that be from staffing, from the compensation of employees, through to the goods and services, and let us hope that they have a very good handle then on the goods and services and are able to manage those numbers, because clearly they needed to manage quite carefully certain aspects of that overall budget. It is also good to see that money is going into that whole aspect of maintenance, rehabilitation, and infrastructure. So I think just covering those broad areas, I would like to support this vote and move then that we support the budget that has been granted the appropriation to the Health and Wellness Department. Thank you, Chair.
Thank you, Member Van Wyk. We're going to come back to the adoption or the rejection of the budget. I noticed the hand of Member Walters and thereafter Member Van Vogel. Member Walters, you may go.
Chair, I would like to propose that we support the budget vote. Thanks.
All right, we're coming back to that. Member Van Vogel.
I'm also on the same page as Member Walters, but mine is different. I will make use of Rule 90, Chair.
All right, okay. Let me release you guys. I think I'm the one who's holding back the laces here. We've dealt with the tabling of the appropriations for vote 6. We have engaged with the content thereof. Let me then pose the question and say that can we then now have the indications of the adoption of vote 6? I take note that it's recorded that Member Van Wyk has indicated that we should adopt, so that Member Walters also indicate the same. Either or can then be used as the one proposing and the other one supporting. Member Van Vogel, you've indicated that you want to make use of Rule 90, which gives an opportunity for an opposition to the vote. And I see Member Stevens, I see your hand.
We are not supporting the budget, and we are making use of Rule 19. Yes, Chair.
All right, I've got yours. I'll come back to putting it together, Member Van Vogel. Member Stevens?
We're supporting the vote, Chair.
Member Stevens is supporting, the PA is supporting. Member Van Binnen?
Just to say that I also support the budget. Thank you.
Thank you very much. So then, colleagues, can I then read the recommendations? It will then read as follows. The Standing Committee of Health and Wellness report that it considered vote 6, which is health and wellness, in the schedule to the Western Cape Appropriation Bill, B2/2025, referred to it in accordance with Standing Rule 188. It reports as follows. In terms of Rule 19, the African National Congress expressed its minority view to not support the vote Or let me read on the screen. My apologies. My apologies, Nomonde. The committee report reads then as follows. The Standing Committee on Health and Wellness report that it considered vote 6, which is health and wellness, in the schedule to the Western Cape Appropriation Bill, B2/2025, refers to it in accordance with the Standing Rule 188, reports that it supports the vote. In accordance with Standing Rule 90, the African National Congress expressed its minority view to not support the vote. That is noted and that is recorded, members. We will then now deal with other matters, which is outstanding reports and minutes of previous meetings. Can I then, Nomonde, I don't know, I know that you have emailed the outstanding minutes for us to consider and to adopt. The minutes of the 14th of April, 14th of February, colleagues, our visit to the Karl Bremer District Hospital. Can we then consider and adopt those minutes? I see your hand, Member Van Vogel.
Yeah. Where you? Yes, sir.
Are you proposing that we adopt the minutes of the 14th of February, the Karl Bremer visit?
Yes, yes, sir. Yes.
Thank you,
Yes, Chair.
Member Stevens. I see your hand. Member Stevens.
I second that, Chair.
Thank you. That is noted accordingly. Member Van Vogel proposed and Member Stevens seconded that. Can we then, Member Van Binnen, I see your hand.
Well, just for the sake of it, I'll third it.
All right, that is now being enforced. We go with the minutes of the 14th of Feb. Our last set of minutes, members, is the minutes of the 21st of February, where we dealt with PEPFAR and the executive order of the President of the USA that has affected US aid to South Africa, that assistance. Can we have a proposal for those minutes of the 21st of Feb? That was the US aid funding withdrawal. We've dealt with that. Can I have a proposer? It's proposed by Member Van Wyk and it's seconded by Member Stevens.
Yes, Chair.
In that order, thank you very much. Once again, the members, thank you very much for a constructive engagement. And the meeting is therefore adjourned. We will see each other in the House. I think it's on the 7th of April. Thank you very much. The meeting is adjourned.
Thank you, Chair. Bye-bye.
Thank you, everybody.
Thank you very much.
Enjoy your
Yeah, bye-bye.
weekend. Thanks, guys.